So I was asked to review PDE-4 inhibitors, and the theme is new developments. And depending upon where you live, you've had a PDE-4 in your armamentarium. At least in the United States, we had it essentially around the beginning of 2017. How many people are in countries where there is no PDE-4 available yet? So a fair number. It's an international meeting. So what I thought I would do is to run through the space of phosphodiesterase 4 inhibitors, a little bit of background where they came from, stress some of the core data that's been presented on crisaborole, but also the other PDE4s that I know about. Now, the way we access information in drug development is sort of tricky because there are things we know about, and then I don't hear anything further about that. There may be no further literature. We don't know if the drugs are on hold, if they'll be further developed or not. And then, of course, there's information that we may hear about that's just not yet published or presented. But I'll also let you know what the literature reflects and new studies that help to change our information. I think I've been involved with each of the drugs that I'm discussing, not necessarily with each company that had them, because several of the drugs are being developed from an international standpoint, not under the aegis of just one pharmaceutical company. So the initial recognition of phosphodiesterase 4 was first brought to dermatology by John Hannafin. It was first noticed in leukocytes, actually, in patients with asthma, that increased phosphodiesterase 4 activity was associated with decreasing intracellular cyclic AMP levels in circulating blood leukocytes in atopic patients, and raised the questions of whether PDE-4 inhibitors could decrease and reduce cytokine mediator release. And this is not the first paper, but this is one of the first papers by John Hannafin that discussed using a specific blocker to try to decrease inflammation in atopic dermatitis. And one of my takeaways is that, so this was looking at a variety of cytokines with techniques that were current in the mid-90s, and the other end of this talk will discuss a look at one of the PDE-4 inhibitors using more modern techniques. But it took from the mid-90s until the end of 2016 for us to get an approved topical PDE-4 for atopic dermatitis. And this is just, I think, a decent representation of some of the mediation that is considered to be associated with inhibition of PDE-4. And you can see it's a variety of cells and a variety of cytokines and a lot of both primary and secondary effects. This is the diagram I usually use when I'm lecturing to practicing dermatologists to sort of translate into localized inflammation in the skin that's partially mediated by inflammatory cells, and then we are topically putting on an agent that has to get absorbed into the skin and then mediate through the cellular mechanism the decrease in overactive PDE-4 by blocking it, decreasing it, and hopefully translating into the clinical response, which of course it has in clinical trials. So there are several development programs that have given us the drugs that we have presently. They are distinct chemical compositions that inhibit PDE-4. I do not know how the different molecules may bind differently. We know there is more than one receptor that mediates PDE-4, and we'll go through that later, but these are the chemical formulations. So crisaborole, I'll spend most of the time. That has the only drug approval right now in the world that I'm aware of for topical PDE-4. OPA 15406, also known as MM36, also now labeled by Bifimelast. And then E6005 or VT501, which had been in development, not sure if it's going further, and Roflumilast, I'm listing because it was one of the first ones that was studied. I don't believe it's in active development as a topical PDE-4 now, but I don't know everything, and happy to hear about it at break if people know that information. So crisaborole was formed by the company Anacor. It's now in the hands of Pfizer, and they structured their company based upon using boron added into cyclic structures to influence the targeted binding of this agent. And eucrisa certainly now has a rich published literature don't have time to go through the pharmacokinetic and maximal use studies, which were done to first display how much absorption there was with topical crisaborole and relative efficacy in phase 2s, leading to the phase 3 study. And the phase 3 study design was a traditional 2 studies, placebo-controlled study. But in this case, in both the long-term and long-term 1-year use, as Robert so well laid out, is necessary for chronic use drugs, and the core clinical trials were done together. So the study design was essentially 2 parallel studies at the same time, about 1,500 individuals who were randomized 1-to-1 to topical crisaborole or the vehicle. After the 28-day time period, they were rolled over into an open label where everyone was then given eucrisa, those who had previously been on crisaborole, those who had not been on crisaborole, but we didn't know it at the time, and they were rolled in. But in the long-term use, to look at the long-term data, the way it was done is patients were evaluated, and if they were clear or almost clear, they withheld the use of topical crisaborole, and then were seen a month later. If they had active eczema beyond an IGA of clear or almost clear, they used the drug twice a day until the next visit. So there are patients who were treated potentially continuously, or patients who were continued on and off over the period of time, up to a year. As soon as they had their basically 100-something patients who made it to a year, the study was concluded. So the core outcomes, this is not new data, since it really was the portfolio that allowed the FDA to approve crisaborole at the end of December 2016. This population was patients 2 onward. So in our core studies, we had patients from 2 to adults included in the study. The clear, almost clear, and 2-step improvement you see was reached in 32.8% in one study, 31.4%, and the vehicle 25.4 versus 18. So different study results, both had to make it statistical significance. Efficacy, but not a huge differential efficacy as compared to the vehicle, but of course a well-designed vehicle. This is looking at the clear and almost clear, but not the requirement of 2 steps. So if mild patients made it to almost clear, they counted, and shows an efficacy at the end of the 4 weeks of treatments of around 50% made it to clear or almost clear, but a low 30% in the vehicle control. There was early improvement in pruritus. Actually, you already saw different representation of that data. Not a marked difference, but a statistical difference in the population. And there are several other studies that have showed antipruritic effects of this topical PDE-4. The long-term study, I happen to be a first author on it, was based on that 1-year use study, though it was variable durations during that time period. And the takeaway, both from this and from the experience in open use so far, is that the drug appears to be quite safe. Now, in the clinical studies, there was a 4% rate of stinging and burning. There have been variable articles in the literature about what that rate may be now that the drug's in primary practice, seemingly higher. But the low frequency of treatment adverse events with topical PDE-4 in the study, upper respiratory infection in 10%, some atopic dermatitis flares. No evidence of laboratory abnormalities. There's no need for laboratory monitoring. No safety signal was seen in this study. Now, what's missing in the study design? It's so interesting to see how atopic dermatitis is in a different state than what it was in the 3-4 years prior to the 2016 approval, because I don't think any drug company would ever dare to do a study without an EASI or a SCORAD anymore, as the home group, the Harmonization of Outcome and Measures group, has really staked out the necessary prerequisites for standard studies. But at the time that this study was done, an EASI score and SCORAD was not included. So I can't tell you how the head and neck did, because there was no regional scoring scoring, which was basically they did a localized skin score, and they did body surface area, and they did the IGA, and that was it. So it's something that was missing. Now, retrospectively, they have gone back and in prior Congresses presented a look at some of the outcome measures of localized skin scores. They had used an ADSI score, which is Atopic Derm Severity Index, comprised of scores of pruritus, erythema, excoriation, exudation, lichenification, and they assigned a number to that, and the ADSI score, therefore, could give you a 0 to 15 range for target lesions, for a lesional assessment overall. And the ADSI severity bands, basically you can come up with what a moderate score would be, mild score, clear, almost clear, severe. So interestingly, the companies went back and did a retrospective assignment of what the lesional score was on patients. Now, the study studied patients who were mild to severe based on IGA, but their lesional scores actually varied. And there are some patients with ISGA, let's see, up here. Excuse me, let's go back. Okay. So all the patients were either mild or moderate in terms of their global score, but about 33% of the patients actually had severe target lesions at the time of the score. And then looking at the outcomes, they showed that even the severe patients made it to clear or almost clear ADSI score of only 12.6%. It's clearly differentiable from the vehicle. And similar, but most of the 38.4% of those in the crisaborole group made it. So you could see a differential response showing efficacy of the drug even more so in the severe population than necessarily in the milder population. And this is just the pooled data showing the change in time. So lesional severity score was sort of looked as a surrogate for EASI score in this population. An analysis of adverse events was also done by race and ethnic group and essentially showed no significant difference in subgroup analysis from a safety perspective. There are several quality of life studies that have been published, this one by Eric Simpson and colleagues, showing that both the Child's Durham Life Quality Index and DLQI showed benefit with topical crisaborole. But there was also a meaningful statistically significant difference in quality of life in those treated with the vehicle as well, those statistically superiorly better for crisaborole. And a recent paper that actually correlated the QOL effect of topical crisaborole with decrease in itch. So there's a very strong correlation in itch response with quality of life, okay? So further literature includes quality of life studies. We haven't seen no differential in side effect profile affected by race, ethnicity, and other pruritus data that's just been published. What we don't know about topical crisaborole, so we still don't have comparative efficacy. I can't tell you about regional responses, though I think stinging and burning in clinical practice is more in facial areas than other areas, at least by my reckoning. Best ways to avoid stinging and burning, there's variable things that people will do around the world. Now, this is actually a very interesting paper answering a question. Many times there's variation in terms of whether one puts a topical medicine on before a moisturizer or after a moisturizer. That was asked of Pfizer, who had this particular drug in hand, and they answered it in relationship to topical crisaborole, with the punchline being that the top row shows you that if you put crisaborole on skin itself without a moisturizer, you get the highest level of penetration. And if you moisturize prior to application, you decrease the penetration. So summary is that co-administration, the sequence of putting a topical directly on can, number one, influence penetration. Is probably the standard way. And I consider anyone in the topical realm to consider doing these sort of co-administration sequence studies as part of their development process. Now on to other PDE-4 developments. So Eisai had a PDE-4 that was then in the US developed by Roivant and Dermavant. And we have sort of mixed data, but not up-to-date data in terms of the development. This was back in 2016. It was a traditional adult vehicle controlled study, a phase 2 dose ranging study, and showed a decrease in target lesion scores without significant adverse events, so there was atopic derm progression in a very small study of 80 patients. And that's the last we've heard of this development in terms of published material. Okay? Now, difimilast has been developed by Otsuka, and my understanding is that's well along the way in phase 3 trials. It's been, in the US, happened to be licensed by Metametric, so I'll show you a few published either posters or reports, but this is sort of an evolution. Now, there have been several publications, including a presentation recently at the SID, that states that PDE-4 binding may influence the utility of the topical PDE-4. There are 4 subtypes, A, B, C, D, of PDE-4, and there are some statements in non-clinical studies that certain subtypes may be more effective at blocking lines of T-cell inflammation and other inflammation. I have been very consistent in the last 3 years in saying that I have no knowledge how this will translate clinically at all. Basically, you know, the proof of the pudding's in the eating. So until you see a clinical response that's differential with one topical PDE-4 compared to the other, I don't know if targeting the receptor necessarily will translate into more effective products. So the first presentation was a few years ago of this PDE-4, and then in Japan in parallel, showing what looked to be a decent dose response, with 1% doing better, 59% of patients making it to clear or almost clear, comparative vehicle at 20%, tacrolimus comparator at about 33%. A version of this was published by John Hannafin and colleagues, it's the same drug, but using the OPA label. And I do know, and this in fact, similar results, marked statistical significance as compared to the vehicle at week 2, 4, and week 8. We have seen, there was a poster at the AAD, which was a PK study. I actually was the first author on the study. This has not been vetted other than through the poster group, not yet published, but was interesting. This was showing the efficacy data with this topical, but the pharmacokinetic data I still haven't seen. It wasn't published in this particular study. And we do know that in Japan, OPA 15406 has completed its phase 2s in children as well, with what looked to be decent outcomes. This was a phase 2 dose finding, particularly in 2 to 12-year-olds, had 38% of patients who made it to clear or almost clear, 40% in the 1%, and 8% in the vehicle. But again, this is data that we saw in partial poster presentation. I don't have further input on it. Now, for those people who want to know everything about topical PDE-4s, just go through a few other things in the literature. This was a really good paper that just came out. It was a meta-analysis of topical PDE-4s in JAMA Derm by Yang et al. It has the usual issues with meta-analyses that starts with a lot of papers and then says, oh, there are only 7 that make it to our criteria for review. And it represents the drugs that we discussed already to date, but this is a resource for you. But the meta-analysis did look at outcome measures, first of all, on its impact on target lesions, and showed that PDE-4s at different time points would actually reach up top. 7 days is the first set of bars, 14 days, 28 days. So just showing efficacy of the PDE-4 as compared to the vehicles. Almost clear outcome measure took a little bit more time period to get that differential with PDE-4s. And their comments about meta-analysis of treatment-related AEs, pain, burning, pruritus, stinging, erythema, higher rates with PDE-4s than with vehicle, but nothing else that was seen in this meta-analysis. Now, clinical practice. Where do we sit with PDE4s in clinical practice? We're starting to get articles that are coming out that are incorporating topical PDE4s in regimens. There's a big leap that has to happen, though, from our clinical trials, which are monotherapy as compared to vehicle, and what we do in real life, where we may incorporate drugs in sequence or in parallel, whether it be with topical corticosteroids or topical calcineurin inhibitors. We're very much looking forward to maintenance therapy studies as well going forward, but this is the first paper that included a topical PDE in a regimen. They didn't include it in mild atopic dermatitis care, but they really don't even talk about other than topical corticosteroids, but there it does use it as a consideration as an alternative, and then it gets listed for moderate as part of the standards. EADV, at the time that the EADV guidelines came out, topical crisaborole hadn't been approved, so it's listed in the upcoming topical therapies. So we'll have to wait for the evolution in clinical practice. Last, I wanted to end with this paper. I thank Emma and Robert for both doing the studies and supplying the slides. And this was looking at using our more modern techniques to see how a topical PDE4 may mediate atopic dermatitis as compared to vehicle. This was a very aggressively designed study with topical application. These were adults who had mild to moderate atopic dermatitis, and basically they were brought in, screened. They had biopsies performed. They had topical BAD application. Then they had biopsies again and evaluation for both gene expression markers as well as physical marker changes, including transepidermal water loss. And quickly, basically, what you see is that crisaborole is compared to vehicle. The total clinical lesion sign decrease. That's just sort of have something in place to show that there was a clinical change. Lesion pruritus was decreased, transepidermal water loss was decreased statistically significantly, and the lesion score. But here we get into our gene expression, and just to start off, if you look at the day one normal skin and day one so the normal skin is mostly blue. Day one in the crisaborole group is mostly red, and day one in the vehicle group is mostly red because these are randomized patients, okay? So basically, red's inflamed atopic dermatitis and blue's more normal. And then you see over time that with a topical crisaborole, you get a lot more blue, and you get a little bit better in the vehicle. You get less red, but not quite as red. So basically, with crisaborole, you get much more of a return to non-lesional expression. Okay? And only modest modulation seen with the vehicle. So even though, in the clinicals, there's that tight difference between vehicle and the topical crisaborole, here you can see it very nicely. Now, these are busy charts, but just basically, if you start with me on the left, day one, basically, there are genes that are upregulated and are downregulated. And what you want to do is show that dysregulation normalizes towards the normal line over time. This says day 8, day 15, and that's what happens in the topical crisaborole group, but they stay sort of dysregulated in the vehicle group. And then basically the punchline is that a lot of mediators that are important in atopic dermatitis seem to correct in the correct way with a topical crisaborole. So it gives us a more sort of modern approach towards looking at some of the impact of PDE4s. So summary, we've had several products that have been in development, one that's approved. We have evolving displays of their efficacy. Safety issues, tolerance is probably a bigger issue than safety in terms of some patients stinging and burning. Development program is very variable, so I'm interested to hear what happens internationally on it, and further studies. So realize that in the United States and most of the world, we do not have a non-steroid topical that's approved for atopic dermatitis. So we know that topical crisaborole studies are pretty much done. We look forward to a readout for that because it would be lovely to have a non-steroid. And for other people here who are looking forward to the future, We would be very excited to have other non-steroids that are effective and yet safe under age 2. And then, of course, I'm highly encouraging of any company and or investigators to look at increasing our portfolio of topical medications that can be studied for long-term disease control, whether it be proactive regimens or maintenance regimens, getting beyond our short-term trials, because while in the United States we have no drug that's approved in that way. In Europe and other parts of the world, topical tacrolimus has been approved in a proactive way, but something I think is very important in topical drug development. We'd love to see that with the PDE4s as well. Thank you very much.